My vision for personalized health is that we now begin to stratify and we leave the one-size-fits-all system. We need to begin to focus on what is the well-being and what is, how do we help people to have a high quality of life during the lifespan. So that means that instead of just focusing on having a health system and how we can treat people when they're ill, we should actually have a focus on how can we avoid treating as much as possible and still have a good lifespan. There are several big opportunities in this. We normally see a focus on improving things that we already do today. We don't focus so much on what we are not doing well. So one of the things where we should focus really hard on this is to have our vision on the underserved. So in every country in the Western world, we have around 20% who are not doing very well in society, who have a lot of challenges, and we are not very good at helping them, even if we still use a lot of resources on and for them. So that's one area where we could be much more precise and personalized and use this. The other part is that personalized health does not only think about or focus on the clinical side, but looks also at the lifespan from cradle to grave. And here, lifestyle, prevention, early detection, and also stratification and risk factors that you can look at. So we begin to also adapt to the individual person. So that's one side, but it's both a personal person side and a personal systemic side. And we haven't really begun working with the personal side. So what we need is to make data and knowledge accessible and usable for the individual person, where they self, the ones who can, the 80% who can, take more responsibility and use information and knowledge to have a better lifespan with a higher life quality. And that also means that we need to change all the way around of just thinking that systems, being private, public, or philanthropic, just sit on data and use it in their own system. So the opportunity here is that we can reallocate a lot of the resources to where they make much more use and benefit than we see today. Apart from that, it's also to go beyond our traditional clinical understanding of health. When we use this strict clinical understanding of health, we only begin working with health, which is working with disease when the disease is already knocking on the door. So we should have a constant focus on being well and not just looking for help when we are ill. We have several challenges in this. One part is the way the business case is in health or the reimbursement. So we generally only pay for actions in a clinical setting, so direct input. And if we measure outcome, we measure it on the outcome on did we do the treatment or not so much did this help on a long term. So the reimbursement system has to be changed. Our notion of data has to be changed. The discussion on data, not just in Canada, everywhere, goes on should it be the individual or the organizations, the system that sits and owns the data, and that's a wrong discussion. We need both. Both need to have access to it, but that means that we need to leave the what we normally label the Silicon Valley data model, that you put value on data on itself. Data needs to float free, so we should have payment for the functions of data, not for the data itself. And that's a huge change. It's also a huge change in legal frames, who is responsible for it. And we need to give the individual person much more access and right to use data on their own terms and in different settings on it. So that's a huge change which is needed. The other change that will come is that genomics and the different new biology omics that are coming, they will have a huge impact. So we can't just sit and say, okay, we don't really believe it comes, or it's too dangerous, or it's too difficult. We really need to make the frames before we come into challenges with it.